Hi, good afternoon. Thank you for listening to this presentation. Today we'll be talking about rescue TEE. And for those of you who don't know me, my name is Ed Avery, and I'm a cardiac anesthesiologist. I work at University Hospital's Case Medical Center in Cleveland, Ohio. In the way of disclosures, I have none relevant to this presentation. Our objectives today are to review 4 non-cardiopulmonary bypass cases that involve the unplanned use of transesophageal echo. And we'll start with case 1, which involved a car accident. It was a 53-year-old female who presented to the Mass General Emergency Ward, status post MVA, unrestrained passenger versus pole. Her injuries included a right femoral head fracture, both liver and spleen lacerations. A descending thoracic aortic false aneurysm was diagnosed with CT, with a localized hematoma, as well as an upper descending thoracic aorta, which was suspicious for dissection versus a contained rupture. The patient was scheduled for urgent descending thoracic aortic percutaneous stent grafting. Okay, in this preoperative study, in a CAT scan, we can see around the aortic arch that there's some, looks like some extravasation of fluid versus edema. And over here at screen right, this is a cut of the descending thoracic aorta, and there's actually extravasation of dye around here, also indicating some possible disruption of the aorta. At this level, we can appreciate with zoom that there does appear to be intimal disruption posteriorly of the descending thoracic aorta, although the fidelity of the image is not strong enough for us to tell exactly what's going on. But it does appear that there's blood and some disruption of the intima. So, an urgent intraoperative TEE was requested by the vascular OR staff to rule out any undiagnosed thoracic aortic pathology prior to stenting, because CAT scans as well as TEEs can miss aortic dissections. It's very dependent on the hemodynamics. When these patients are treated with antihypertensives in the acute care setting, we can decompress the dissection flaps, and then they don't show up on CAT scans or show up on TEEs, despite some studies suggesting that TEE has 100% sensitivity and specificity for diagnosing aortic dissections. So we'll ask ourselves in the perioperative period here, what is the most important information that we need from this TEE exam? Now, ideally, with time permitting, we do a complete exam on every patient, but in some cases, a focused exam may be necessary. So in this case, number 1, we want to rule out any ascending aortic or aortic arch dissection or rupture. That is a cardiac surgical emergency. It carries a high morbidity and mortality. The mortality increases about 2% per hour in an untreated ascending aortic dissection. As far as ruling out aortic valve pathology, if there is an aortic dissection, an ascending dissection present, that's very important because we need to make a decision as to whether the valve needs to either be replaced or repaired. There is some good data on that we'll talk about. But first I want to show you a short axis image of the aortic valve and to orient you. This is the interatrial septum. This is the left atrium. This is the right atrium. You can see a portion of the tricuspid valve here. And this is the right ventricular outflow tract here. And all these structures appear to wrap around the aortic valve. Here we're looking at the non-coronary aortic cusp, the left coronary cusp and the right coronary cusp. And there's no indication that there is any dissection involving the aortic root here. So this is a diagram I took from a publication about 10 years old now. It was published in JACC by Eric Isselbacher, Al Hilgenberg, Bob Levine, and Herman Mosevitz, all MGHers, where they looked at the mechanisms of aortic insufficiency in various aortic pathologies, and relevant to us here is panel C, where the aortic dissection extends down into the aortic root. The aortic root is proper is made up of three structures: the sinotubular junction, the sinus valsalva, and the aortic annulus. And you can see here the aortic dissection flap has come down into the left coronary sinus, and you can see the left coronary artery drawn in here, and undermine the function of the aortic valve, causing eccentric aortic insufficiency. Aortic dissection flaps can also prolapse in and out of the coaptation point, often not causing a huge amount of insufficiency, but nonetheless they need to be repaired. The ascending aorta, when it's replaced, which is how this is fixed, will alleviate this problem, and the aortic valve does not need to be replaced in either case if these are repaired correctly. This is a long axis view, mid-esophageal long axis view, and we're looking at a zoom cut of it here. This is the left ventricular outflow tract. This is the anterior aortic root here, and then this is posterior. This is the ascending aorta. This is the right coronary cusp. This is the non. And we don't see any evidence of a dissection flap coming down either into the posterior or anterior root. And the aortic leaflets appear to be coacting normally. It's a good sign. But we always look at these things with color. So we're back to our short axis image. And we can see flow in the left main coronary artery, the left coronary cusp, the non-coronary cusp, and then down here the right coronary cusp. And there's no evidence of aortic insufficiency. In the long axis with color, we can see that there's also no evidence of aortic insufficiency. Heart seems a little hyperdynamic, but certainly no evidence of aortic insufficiency during diastole. We'd see color going backwards here when the aortic valve closed. In the descending thoracic aorta, we're looking here at what is the anterior wall, and we can see some intimal thickening, but no evidence of aortic dissection. And we can see what may be a collection of blood or clot, possibly an intramural hematoma outside of the aorta anteriorly. In the long axis, it is clear that there's an echogenic signal here consistent with hematoma. There's some clotted blood. Fluid blood remains non-echogenic or echolucent, the darker signal. And with color on here, we don't see any flow acceleration in this collection, which is a good sign. Now, looking very carefully, we do find one area anteriorly where it does appear that the aortic intima is disrupted. And with color Doppler, it's actually easy to appreciate that there is some flow through this, very regular looking flow, likely not a blood vessel, but probably a tear in the aorta bleeding out into the periaortic tissue. So this is exactly where the surgeon wants to put his percutaneous stent, and you can see him getting ready. His catheter is ready to go, and the balloon is starting to inflate. And this is actually hard to appreciate in echo, with echo, but in the long axis, I think you can see right here that the stent was just deployed. They're not extremely echogenic or easy to see, and that took care of the problem. The remainder of the intraoperative course was uneventful, and the TEE was successful in ruling out pathology in both the ascending aorta as well as the aortic arch. Okay, case number 2 is that of a 70-year-old male who presented for left partial nephrectomy with a combined general anesthesia and regional anesthetic, a thoracic epidural. He had a history of bladder cancer, which is why his left kidney was being removed. His past medical history was significant, as you can see, for hypertension, peripheral vascular disease, hypercholesterolemia, left ventricular hypertrophy related to his hypertension. And he had had a treadmill stress test 3 years prior, which was read out as non-diagnostic for ischemia, although he had a left anterior fascicular block, which makes interpretation of that particular exam a little equivocal or confounded. Now, intraoperatively, the patient had a functional thoracic epidural. They were induced into general anesthesia and noted to have a very labile blood pressure. Invasive monitors were eventually added to follow the blood pressure and treat it more appropriately. Soon thereafter, the patient experienced a VFib arrest, and a rescue TEE was called for. Now, when we're called into the operating room for acute hypotension, there is a laundry list of things that we need to think about. Not all of them require TEE to make a diagnosis, and this is a list I got from my colleague in Boston, Scott Streckenbach, and I won't go through the whole list, but you can see obviously hypovolemia, low tone states, problems with the cardiac rhythm, possibly a problem with the heart, tamponade, some aortic injury, any air or clot. Monitor infidelity is, as well as a medication error, should also be considered. And here we have a graphic of the anesthesia record. I've drawn a green line across at a pressure of 100 toward, and you can see after induction around 8 o'clock that the blood pressure was jumping around quite a bit, and they added an arterial line at about 8:45 to try and stabilize the blood pressure. They added some phenylephrine to keep the blood pressure up. The case went about another hour or so, and the patient became hypotensive, not responding as well to phenylephrine, and thought not to be related to the thoracic epidural. And ultimately, right about here, at 11:45, the patient fibrillated, received CPR, multiple rounds of ACLS drugs, and that's when the rescue echo was called for. So let's see if we can help determine what's going on with this gentleman. Well, this is a mid-esophageal 4-chamber view, left atrium, right atrium, interatrial septum bowing to the left, indicating very high left atrial pressure. This left atrium is also dilated. Here's our left ventricle and right ventricle. The left ventricle is also dilated, and if you look at it, there's not much thickening during systole. There's not much motion at all. So this is an extremely hypokinetic to akinetic left ventricle, indicating a severe and acute ischemic event going on. And we put on some color Doppler to assess the competency of the mitral valve, because frequently when the ventricle becomes ischemic, the mitral valve can become incompetent. In this case, blood pressure was so low and the heart was so weak, I don't think it could actually generate any significant mitral regurgitation. This is a transgastric short axis view at the mid-papillary level. Here's our anterior wall, lateral wall, inferior wall, and septal wall. And what we do is just go around in all the segments and we look for thickening. And we don't see much thickening at all. Severely hypokinetic to akinetic inferior wall, and there's some dropout here in the septum, but we can see it's not thickening and not moving well. So what this looks like, unfortunately, is severe acute ischemia of the anteroseptal, anterior, anterolateral, and even the inferolateral wall. So probably a left main equivalent lesion or a left main disruption, probably a plaque ruptured in the left main. Now here's the short axis again of the aortic valve, interatrial septum here.